Okay, this is the series 2 of the Uworld question bank video. A 26-year-old man is hospitalized after he was found in the park shouting and laughing to himself. He insists on wearing a cap lined with several layers of aluminum foil and explains that the hat prevents laser beam from reprogramming his mind. For the past 3 years, the patient has been hearing voices of his deceased mother, the devil, and world famous singer. He has had one previous psychiatric hospitalization during which he responded well to haloperidol. However, the patient stopped the medication shortly after discharge because he did not like the way it made him feel. A decision is made to administer a second generation antipsychotic medication compared with first generation antipsychotics. This class of medication is associated with which of the following? Greater efficacy in terms of treatment of positive psychotic symptoms, greater risk of anticholinergic effects, greater risk of tardive dyskinesia, lower risk of acute dystonia, lower risk of metabolic adverse effects, or lower risk of seizures. Okay, it has lower risk of acute dystonia. 69% people have marked it correct. So common antipsychotic side effects are, of the first generation, there will be low potency, which is haloperidol, extrapyramidal symptoms like acute dystonia, akathisia, Parkinsonism, tardive dyskinesia, and low potency example chlorpromazine, sedation, cholinergic blockade, orthostatic hypotension, and weight gain. Second generation antipsychotics will have metabolic syndrome and weight gain and extrapyramidal symptoms, which are less common than first generation. So this patient is experiencing an acute psychotic episode, which is delusion, hallucination, disorganized behavior, most likely due to schizophrenia, a chronic psychotic illness with typical onset in the young adulthood. His treatment history includes a good response to the first generation antipsychotic haloperidol, but poor adherence because of tolerability issues. As a class, these first generation antipsychotics are associated with high risk of extrapyramidal symptoms due to their potent D2 antagonism. Types of EPS effects include acute dystonic reactions, drug-induced Parkinsonism, akathisia, and tardive dyskinesia. Second generation antipsychotics are often used for first-line treatment in schizophrenia due to their lower risk of EPS compared to FGAs. Since, however, SGA are associated with weight gain and metabolic effects, including the prevention of diabetes. Side effects profiles of individual SGA vary. Olanzapine and clozapine are associated with greater risk of metabolic effect. So second generation antipsychotics are often used for the first line treatment of schizophrenia because they have low risk of extrapyramidal side effects. So that is why the answer is low risk of acute dystonia, because dystonia is extrapyramidal. Acute dystonia, akathisia, and Parkinsonism, as well as tardive dyskinesia, all of them are extrapyramidal. But the second generation have more risk of metabolic syndrome and weight gain. Okay, 54-year-old man with history of cirrhosis was brought to the emergency department by his wife, who found him agitated and confused. She reports that he was nauseous and vomited bright red blood several times yesterday. His cirrhosis is secondary to chronic hepatitis C infection, and he has received treatment for esophageal varices in the past. Physical examination reveals abdominal distension, decreased liver span, and testicular atrophy. A jerky, irregular flexion extension tremor involving his hands is seen with wrist extension. Which of the following is most likely to be elevated in this patient's astrocytes? Decreased liver span and testicular atrophy. So he has hypogonadism. And he also has varices. So I think maybe he has cirrhosis, because cirrhosis has all this. Yeah, they've given his cirrhosis is secondary to hepatitis C. A jerky, irregular flexion extension tremor involving his hands is seen with Wrist extension, which of the following is most likely to be elevated in this patient's astrocytes? Alanine, aspartate, carbamyl phosphate. It is glutamine. Effect of hyperammonemia in the glutamate-glutamine cycle. So from the cerebral capillary, ammonia comes accumulation of glutamine by glutamine synthetase. This leads to swollen astrocytes. And then this glutamine goes to presynaptic neuron, and then glutaminase acts and converts that into glutamate. So this patient has a hepatic encephalopathy likely due to his recent GI bleeding, causing corresponding increase in nitrogen absorption from the gut. The pathogenesis of hepatic encephalopathy is related to increased circulatory levels of ammonia and other neurotoxins due to failure of the liver to metabolize the waste products. So under normal conditions, astrocytes regulate neurotransmission by taking up glutamate present in the synapse, preventing excessive neuronal excitation. Through the action of glutamate synthetase, glutamate undergoes a condensation reaction with ammonia to form glutamine, and glutamine is then released by astrocytes and taken up by neurons, which is converted back to glutamate for use as a neurotransmitter. So that is our glutamate-glutamine cycle. So when excess ammonia is present in the blood, it crosses the blood-brain barrier and it is taken up by astrocytes, increasing this glutamine production. The presence of excess glutamine within the astrocytes leads to increased intracellular osmolality, causing astrocyte swelling and impaired glutamine release. Hyperammonemia consequently decreases the amount of glutamine which is available for the conversion to glutamate in the neurons, resulting in disruption of the excitatory neurotransmission. So hyperammonemia and advanced liver failure occurs as a direct result of cirrhotic liver's inability to metabolize nitrogenous waste products. Ammonia crosses the blood-brain barrier and causes excess glutamine to accumulate within the astrocytes. This decreases the amount of glutamine available for the conversion to glutamate in the neuron, resulting in disruption of the excitatory neurotransmission. So that is why when there is disruption of the excitatory neurotransmission, he has these symptoms of tremors and everything, because excess ammonia crosses this barrier. It increases glutamine production. Presence of excess glutamine within the astrocytes leads to increased intracellular osmolarity, causing the astrocyte swelling and impaired glutamine release. Hyperammonemia consequently decreases the amount of glutamine available for the conversion to glutamate, resulting in disruption of the excitatory. So glutamine to glutamate conversion does not take place. I don't know. I think this is a really difficult concept for me to grab, that when excess ammonia is present, it crosses the blood-brain barrier, it is taken up by astrocytes, increasing the glutamine production. The presence of excess glutamine within the astrocytes leads to increased intracellular osmolarity. So this causes swelling and impaired glutamine release, and hyperammonemia consequently decreases the amount of glutamine available for conversion to glutamate in the neurons. So next question is, a 14-year-old boy is brought to the emergency after accidental ingestion of chicken bone that lodged in his esophagus. So a mutation in which of the following receptors is most likely responsible for this patient's lab abnormalities? So his lab abnormalities show borderline PTH, high PTH, very low urinary calcium concentration, and normal 25-hydroxy-vitamin D. So upper endoscopy is performed and the bone is successfully removed. However, the patient is incidentally found to have mild hypercalcemia on the lab testing. On follow-up with his primary care provider 2 weeks later, he has no symptoms and clinical examination is unremarkable. Further questioning reveals that several of his family members also have mild hypercalcemia. Subsequent lab studies show a borderline high PTH concentration, very low urine calcium, and normal 25 hydroxy vitamin D. So all these family members, they have hypercalcemia, they have high PTH. So mutation is going to be, first option is intracellular receptor with DNA binding domain. No, I don't think that is likely. Membrane bound receptor coupled with G protein. Transmembrane ligand gated ion channel. Transmembrane receptor associated with intrinsic tyrosine kinase activity, and transmembrane receptor with activation, causing activation of genus kinase and STAT pathway. So I think this is going to be G protein, or I know it is not tyrosine kinase because tyrosine kinase is involved with insulin, and genus kinase is with histamine, serotonin, etc. But so it has to be either the ion channel, ligand gated ion channel, or it has to be this membrane bound receptor coupled with G protein. So I'll just go with the G protein one. So this is the calcium homeostasis, in which PTH hormone secretion is on one side, on other side we have serum calcium concentration. When there is less serum calcium, then there is increased sensitivity to calcium, sena calcet. And then they have shown normal homeostasis, which is at 8.4, normal sensitivity to calcium. And then they have also shown decreased sensitivity to calcium when calcium is high, as in case of familial hypocalciuric hypercalcemia. So this patient likely has that one. That is why his serum calcium is low. No, serum calcium is high and urine calcium is low. So calcium sensing receptors are transmembrane GQ protein coupled receptors that regulate the activation of parathyroid hormone in response to changes in circulating calcium. So binding of the calcium to CASRs lead to the inhibition of PTH release, whereas low calcium levels allow increased PTH release. So familial hypocalciuric hypercalcemia is a benign autosomal dominant disorder which is caused by defective calcium sensing receptors in the parathyroid gland and kidneys. So in this disorder, higher serum calcium levels are required to suppress the secretion of PTH. This raises the set point of calcium-induced regulator of PTH secretion, and patients with this familial hypocalciuric hypercalcemia, they always have asymptomatic hypercalcemia and reduced urinary excretion of calcium and high normal or mildly elevated PTH. Because calcium sensing receptors are always GQ coupled, so the answer is G protein coupled receptors. Next is the 10th question. A 28-year-old professional endurance athlete comes to the office after his team physician detected a heart murmur. So patient has no symptoms and no exercise limitations, and his medical history is non-significant. His blood pressure is 110 by 66 millimeters of mercury and his pulse is 54 per minute. So physical examination shows a soft systolic murmur which is best heard at the left second intercostal space in the supine position. So murmur disappears when the patient is upright but reappears after brief exercise. Which of the following cardiovascular exercises or adaptations best explains this patient's finding? So this murmur increases with blood flow, right? So it can't be HCM, it can't be PDA. That is for sure. So this murmur is heard at the left second intercostal space in the supine position and is systolic. So it has to be the pulmonary one because pulmonary is, and it has to be pulmonary stenosis. So which cardiovascular adaptation best explains this? First is decreased pulmonary vascular capacitance. Capacitance is delta V by delta P. So with increased blood, no, the capacitance is not going to decrease. Second is decreased vagal tone. Vagal tone is also not decreased during exercise. Increased stroke volume. Third is increased systemic vascular resistance, and fourth is increased ventricle wall thickness. So I'm just confused between C and D because they both look really promising. But yeah, I'll go with C. So increased stroke volume. This is athlete's heart adaptation. Athlete's heart is always going to have endurance training, and high stroke volume is the major common finding of athletes undergoing this endurance training, and this is a professional endurance athlete. In this case, there will be increased left ventricle cavity, eccentric hypertrophy is there, eccentric hypertrophy, and increased right ventricle cavity size, increased diastolic filling and stroke volume, and unchanged left ventricle ejection fraction. So this professional athlete most likely has cardiovascular adaptations of athlete's heart. The soft systolic murmur likely represents a pulmonary flow murmur, a common finding due to high stroke volume that develops with intense endurance training. The adaptations of athlete's heart differ depending on whether intensive endurance training or resistance training is pursued. With endurance training, systemic vascular resistance is reduced and blood volume is increased. So whenever the person is undergoing this training, resistance is definitely going to decrease due to vasodilation in the skeletal muscles. Blood volume is increased, leading to increased left ventricle volume load. So to compensate for that, left ventricle eccentric hypertrophy, that is left ventricle wall thickening, develops, which increases the left ventricle cavity size to increase diastolic filling capacity and facilitate increased stroke volume and cardiac output. So right ventricle cavity enlargement also takes place to increase this diastolic filling and accommodate the increase in cardiac output, because the right ventricle and left ventricle are arranged in series and they contract at the same time. So right ventricle stroke volume must increase to match this left ventricle volume and prevent backup of the blood flow. An increase in stroke volume is maintained at rest and allows for adequate cardiac output at low resting heart rate. The interior location of the pulmonic valve and slightly smaller valve area compared to aortic valve creates this pulmonic flow murmur due to high stroke volume. And murmur is always best heard at left second intercostal space in supine and may disappear when venous return is decreased with standing. Next is the antidote for this patient's current condition most likely has which of the following mechanism of action. So a 25-year-old man is brought to the emergency department after being found unresponsive. He has a history of schizoaffective disorders and previous suicide attempts by prescription medication overdose. The patient was recently started on haloperidol and sertraline, and temperature is 40.6, blood pressure is 120 by 98 mm of mercury, and pulse is 112 per minute. On examination, the patient is obtunded and diffusely rigid without clonus, and laboratory studies show serum creatinine of 3.2 milligrams per deciliter and creatinine kinase of 75,000 units per. Okay. So creatinine is very, very high. Leukocytes are also high. Antidote will have which of these mechanism of actions? So he is taking this haloperidol and sertraline, and he also did suicide attempts. So blood pressure is high, pulse is high. So antidote for this patient's condition most likely has which of the following mechanism of action? First is activation of presynaptic voltage-gated calcium tunnels of motor neurons. Second is antagonism of peripheral and central serotonin receptors. Next is blockade of central dopamine, D2. Next is inhibition of anticholinesterase at the neuromuscular junction. And fifth is inhibition of calcium release from sarcoplasmic reticulum of the skeletal muscle. Actually, I'm very confused with this one, but I know one thing for sure, that since this patient has fever, this patient has rigidity, so maybe he has that malignant hyperthermia in which there is also elevated creatinine kinase and the vitals are also not normal. So maybe his muscles are breaking down. So then we will have to inhibit this calcium release from the muscle. So this is neuroleptic malignant syndrome in which there is fever, there is, I diagnosed that one right. It has fever, it has confusion, it has muscle rigidity, which is generalized, and autonomic instability, which has abnormal vital signs and sweating. So this patient has neuroleptic malignant syndrome, which likely is caused due to overdose of haloperidol. NMS is a life-threatening adverse reaction most commonly resulting from the use of antipsychotic medications which block the dopamine receptors in the brain, and NMS presents clinically with diffuse muscle rigidity, high fever, autonomic instability, and altered sensorium. So lab findings include creatine kinase elevation due to rhabdomyolysis, which can result in acute renal failure. So mainstay of the treatment is to discontinue this causative agent and provide supportive care. Example, the intravenous hydration. In severe cases, dantrolene can be given, which antagonizes the ryanodine receptors and inhibits the calcium release from the sarcoplasmic reticulum. Second option is bromocriptine, which is a dopamine agonist. It has shown clinical benefit in NMS. So neuroleptic malignant syndrome is a life-threatening reaction to antipsychotic medication which is characterized by diffuse muscle rigidity, hyperthermia, autonomic instability, and altered sensorium. So this antipsychotic should be stopped and supportive care provided, and dantrolene, a ryanodine receptor blocker which inhibits calcium release from the sarcoplasmic reticulum, is an effective antidote. So next is 12th. A 19-year-old woman comes to emergency with pelvic pain, fever, and chills that began last night. So patient's last menstrual period was 12 weeks ago and she had a surgical pregnancy termination at the clinic, which is 2 days ago. So temperature is 38.3 degrees Celsius, blood pressure is 92 by 60 pulses 102. Physical examination shows diffuse lower abdominal tenderness without rebound or guarding. Speculum examination reveals an open cervical os and malodorous tissue in the vaginal canal. Bimanual examination shows moderate uterine tenderness and no adnexal mass. So what is the cause of this patient's condition? So malodorous tissue, maybe she has this bacterial vaginosis and it is caused by chlamydia, maybe, I don't know. So she has fever, she has low BP, pulse is high, there is open cervical os and malodorous tissue in the vaginal canal, and bimanual examination shows moderate uterine tenderness and no adnexal mass. Which of the following is the cause? So maybe she has this chlamydia. Oh no. So oh god, she has had septic abortion. Yeah, this was the biggest hint, open cervical os and malodorous tissue. So septic abortion, I should write down this topic which is weak. I think whole of the gynecology of mine is weak, like the reproductive system. Earlier I did the preeclampsia question wrong and now septic abortion. So definitely this is the weakest one. Risk factors of pregnancy termination with retained POC, that is products of conception, and microbiology is Enterobacteriaceae, group A Streptococcus and Staphylococcus aureus. So their clinical presentation is fever, low abdominal pain, malodorous persistent cervical discharge, tender uterus with dilated cervix. So this patient with fever, abdominal pain, uterine tenderness, and malodorous cervical discharge most likely has septic abortion. With surgical pregnancy termination, the cervix is dilated and products of conception are removed via suction and sharp curettage. During this procedure, vaginal flora and other bacteria can enter the uterine cavity. Complete removal of POCs, including placental and fetal tissue, does not usually promote this bacterial growth. However, when incomplete evacuation occurs, then there is bacteria. Then it becomes infected and it results in sepsis and then septic abortion. And the most common organisms which cause the septic abortion include anaerobes. So yeah, firstly, there will be anaerobes like Enterobacteriaceae. Then there can be group A Streptococcus, and then there can be Staphylococcus aureus. So once it is introduced into the uterus, the bacteria can access the intervillous space of the retained placenta, which leads to uterine infection, and bacteremia. So, bacterial toxins can cause tissue necrosis, widespread endothelial damage, multi organ failure, and even death. In addition to broad spectrum antibiotics, patient requires urgent surgical uterine evacuation to remove the necrotic nidus of the infection, where the antibiotics are less effective. Long term complications include synechia. Synechia are adhesions in the uterine cavity that can lead to sensory amenorrhea and infertility, that is Asherman syndrome. So the one which I marked wrong was that chlamydia causes cervicitis and PID. So this is a cervicitis in which there is red inflamed fibril cervix with purulent discharge. And PID also with pain, pelvic pain with fever and cervical motion tenderness. But this is not a vaginal colonizer, so it is not involved in septic abortion. Actinomyces, I heard that one in case of, I think, jaw infections with sulfur granules, sand like granules. But it also normally colonizes the mouth, digestive, and genital tracts. Then, third is lactobacillus, which is found in the vaginal microbiota and it prevents the overgrowth of pathogens through the production of H2O2. In the immunocompromised host, lactobacillus do not lead to this invasive infection. So, Listeria monocytogenes is a food-borne pathogen that is especially virulent in the immunocompromised individuals and pregnant women. It causes spontaneous abortion and intrauterine fetal infection and neonatal sepsis through transplacental transmission. Okay, next. Oh god. This is again the brachial plexus one, and this topic is so difficult. Okay, let's read on. I'm sure I'll do it wrong, but anyways, let's just read on. A 23-year-old man is brought to the ED after sustaining stab injuries in the street fight. The patient feels lightheaded and dizzy, and blood pressure is 110/60, and pulse is 115. So, physical examination shows diffuse bleeding from the penetrating wounds over the right neck and shoulder area. IV fluids are administered and blood transfusion is initiated. Under surgical exploration is performed and injured blood vessels are repaired. Further exploration shows complete transection of a specific nerve, which is indicated by the arrow in the image below. So, which of the following actions is most likely to be impaired as a result of this patient's nerve injury? So, nerve injury. Okay, which nerve is this? First of all, sustaining stab injuries. Right over this right neck and shoulder areas, there are wounds. So maybe it is axillary. Axillary is the one in the shoulder. And axillary is responsible for abduction. So, but this is not axillary. This may be radial. I'm really confused. Which one is this? This can be median, maybe. I don't know. Oh, I just marked it. I'm just lucky. I got it right, but I don't know the answer. So it is radial, extension of the wrist. So this is the brachial plexus nerve. Radial nerve is the largest nerve. So let me just remember all this. Radial nerve is C5 to T1, okay. That is the radial. The first nerve is musculocutaneous, which is C5, C6. Second nerve is axillary. Then third radial. Fourth is median. And the last one is ulnar. So radial nerve is in the radial groove. It provides sensory innervation to the skin of posterior arm, forearm, and dorsal lateral hand. It innervates all the extensor muscles of the upper limb below the shoulder and provides sensory innervation to the skin of the posterior arm, forearm, and dorsal lateral hand. So radial nerve provides sensory innervation to the skin of the posterior arm, forearm, and dorsal lateral hand and provides motor innervation to all the muscle fibers, all the extensor muscles of the upper limb below the shoulder. So that is why damage to this can result in wrist drop, and that is why extension of the wrist is compromised.